Good evening, doctors. On behalf of G Healthcare, I welcome you all on XP Connect webinar series. It's my privilege to welcome Dr. Chander Lulla for today's session on mid-sagittal view, maximum information, minimal scans. Dr. Chander Lulla is well-known sonologist and fetal medicine specialist. He is the head of the ultrasound department at Jaslok Hospital, Mumbai, consultant ultrasound department, Reliance HN Hospital, Mumbai, and RIA Clinic at Mumbai. He has contributed to many national, international papers, journals, and books. He is an ex-IFUMB and ex-ISWAG ambassador for India. Currently, he is a dean for IFUMB Society. So now I would like to invite Dr. Chander Lulla to start the session. Over to you, sir.
Thank you, Zeenat. At the outset, I would like to thank GE and Blue Jeans for making this possible against all odds. As you know, across the country, we are under lockdown, so it's quite a pleasure to do this webinar in this period of time when we are all so stressed to do some educative activities from home. And I welcome you with pictures from Mumbai, although we are in Mumbai and you're across the world. So this is a combination of RIA Clinic, Society of Fetal Medicine, and GE Healthcare. So in this stressful time, you know that the headlines all over today are full of the dreaded coronavirus. So at the outset, I would like to pay my condolences to all the families which have lost their loved ones. Of course, it's a very trying moment, and the authorities are doing their best, and also our medical fraternity is doing our best. And I can only tell you that it is really stressful when we are facing these patients. We faced the first patient at Jaslok Hospital at some time back, and it was quite a task. All our staff was exposed, but thankfully everybody is safe and happy. We have to remember that when the mother is pregnant, she is at extra risk, and we have started getting a lot of opinions on the management of the coronavirus in pregnancy. They are at higher risk of going into labor. They do have breathing difficulty in labor, and 1 out of 20 children can be affected if the mother is COVID positive. If you have fever in the first 4 to 6 weeks, you can have abnormalities of the spine and brain in 2 out of 1,000. And of course, express milk will be better for the child if at all, unfortunately, the mother is affected. Now, with the Society of Fetal Medicine, we are formulating guidelines at a breakneck speed for all of us who will be handling patients after the 14th of April once the lockdown is down, and how to manage these pregnancies. So it'll be ready probably in a week, in a day or two. In the meantime, I urge you to maintain physical distancing. I don't like to call it social distancing because it has an annotation that we're trying to be away from each other. So we have to draw the Lakshman Rekha. Please use the time to make yourself physically active and eat high protein food so that you're immunologically competent to handle this virus if unfortunately you are at it. So let's get down now and hope everybody is safe across the country, and I wish you the safety for all of our fraternity. And now let's get down to our topic. So as we know, when we are dealing with congenital abnormalities, this can affect about 3% of pregnancies as identified by prenatal imaging. And for 30% of these, we have standard genetic tests like karyotyping, microarray, and the cause can be identified. In 70% of cases, the genetic cause remains unknown. A significant fraction of these could be explained by single gene disorders, which we are analyzing. And of course, ultrasound is where we really come in to make a more conclusive diagnosis. We know that a large percentage of first trimester losses could be due to chromosomal abnormalities. So 2/3 of occurred spontaneous abortions that is early embryonic demise can be due to chromosomal abnormalities. Half of recognized miscarriages in the first trimester, as you know, can be due to chromosomal abnormalities. And 5% of stillbirths are also recorded as genetic abnormalities, and also 5 to 7% of infant and childhood deaths. And this is more common with repeated miscarriage and multiple structural abnormalities. As you can see here, a very early 8 weeks fetus with a little extra fluid here, and unfortunately this fetus had a demise. At the other extreme, you have a fetus here with a very irregular shaped skull. So this is what I call as an abnormal contour sign. Compare it to a normal contour here, and this is probably an 8-week diagnosis of early anencephaly. So we can even see the abortus and come to a conclusion that they could be dealing with a genetic abnormality. Now, as we know, we are living in an era of a marked explosion of technology. We have a huge amount of biochemistry that is available. This is basically the combined screening, the beta-HCG PAPE, then we have PLGF and PENTA. Now we have NIPT and other biochemical markers which provide a lot of information. We have virtual explosion in genetic technologies. So we have the earlier FISH and karyotype are becoming redundant. We have rapid tests and more accurate tests, the qF-PCR, BOBS, microarray, which give us more information compared to just what karyotype would give us. And in some specific situations, we can even evaluate the clinical exome and the whole genome if necessary. And virtually ultrasound specifically, you can see here GE has been at the forefront, and we are now rapidly changing in technology, and there is earlier diagnosis which is possible, and this is really helpful for the mother because we can pick up abnormalities before the world comes to know that they are pregnant, and this avoids a social problem. Today's topic is going to be midline sagittal view, minimal image, maximum information, and it is basically directed towards taking a single image and getting the maximum information from that point of view. Let's begin with a little bit of technical aspects. Of course, as you know, we do the NT scan between 45 and 84 millimeters, that is between 11 to 14 weeks. And this is really, really important for all the gynecologists who are on this webinar, because even today we get NT scans beyond this range. A transabdominal transducer is pretty good to give us good images in more than 95% of cases. But of course, transvaginal gives a better imaging, and in some specific situations, we need transvaginal, specifically if it's a high BMI individual, or if there are multiple fibroids, or if there's a uterine abnormality. I must also recommend the use of high-resolution transducers, the C29, the L911, which is available with GE. And these are very good, as you will see in some of the images that I show you. You must remember that the machine should have a caliber of measuring up to about 0.1 millimeter change in diameter, and this is important from the screening point of view. We must magnify the image on the screen to occupy at least 75% of the screen for NT scanning, and then zoom in to the fetal head and thorax for measuring all the soft markers. It's very important that we have a perfect mid-sagittal section, and how do we confirm that? We look at the tip of the nose, the nasal bone, and we confirm the presence of the palate, which is rectangular. There should be a gap between the chin and the chest, and we must confirm the presence of this lucent area in the midline, which is the combination of the thalamus and the third ventricle. And of course, then we will see the posterior cranial fossa a little later, the fourth ventricle and the cisterna magna. But very important is this gap here. The fetus should be exactly in the mid-sagittal section in a neutral position. We can take more than one measurement. Usually we take the largest measurement as the measurement which is valid for that particular fetus. The measurement of the NT is on to on, and we take the maximum subcutaneous lucency and keep the caliper on the skin here and on the inner echogenic line there. You must be careful to see that the fetus has moved away from the amnion, and otherwise you will be measuring a larger distance as the nuchal measurement. And these are some of the very high resolution probes that are available today, and you can see the 9L, the 612 transvaginal, and C29 probe here. I also urge you to look at the first trimester practice guidelines, as you can see in the ISWAG White Journal, and it's a very comprehensive review of how to do the first trimester scan, and here also gives you a checklist of how to proceed and see all the structures. So this is a very important reading. Once you start scanning, it has to be very systematic. Between 11 to 14 weeks, you do sagittal, transverse, and coronal. Of course, today we are only going to talk about sagittal scanning, but as a rule, you scan completely systematically, going through all the various organs and all the various parts, which I won't go through, and this is a complete pictorial description of what are all the 16 views that you get. In each section, you take about 4 sections. This is sagittal, that's the entire fetus, that's the nuchal, that's the limbs of parasagittal, and the spine in sagittal, of course. And I won't go through the rest because it's not part of the talk. When we are talking about sagittal midline scanning, it is extremely useful for biometry, for aneuploidy screening, and for picking up malformations, as we shall see. The first and priority is, of course, the biometry. So we look at the CRL. We look at the body proportions. So the proportion of the abdomen and the head should be symmetrical. They're usually symmetrical in diameter. We have then signs in the central nervous system, like the IT sign for picking up CNS abnormalities. We look at the face and the various facial angles for dysmorphism. We will look at the anterior abdominal wall to look for ventral wall defects, look at the urinary bladder, and of course the spine is important to see directly. Now here again, this is the technique. As I told you earlier, slight flexion will lead to closure of this gap between the chin and the chest, and you will also see that the fetus is slightly rotated due to the presence of this bony structure, the maxilla between the nose and the palate. And more importantly, when you're measuring the CRL, this is an inappropriate measurement. We must have a perfectly sagittal neutral position of the fetus. The fetus should not be flexed, and then we take the measurement. Now, when we are looking at the NT also, we must see that the fetus is in perfect neutral midline position, as in this picture here, with the appropriate gap between the chin and the chest. If you see when there is flexion, you will downgrade the measurement by about 0.4 millimeters, and if there is extension, you will increase erroneously the measurement by about 0.6 millimeters. Now, this video here shows you the gap between the amniotic membrane and the nuchal. So if you do not measure the fetus once the fetus has moved up, you will erroneously measure this gap as the NT measurement. So it's very important that you separate the fetus from the amnion and only measure the true NT that is applicable. The other error that is possible is sometimes when you have the fetus in this prone position. I know that this can be quite frustrating if the fetus doesn't turn, but it may be advisable to make the mother walk a bit or shake the tummy to see that we get a better position. And you can see that in the supine position, you may in the prone position, you may underestimate the measurement. And these are 3 images of the same fetus, and actual measurement was about 3.7 millimeter in the supine position, whereas it was getting underestimated in the prone position. If inadvertently there is a cord in the image, there is no problem. You can measure either above or below and take the maximum measurement at that point of time. As I said earlier, transabdominal is pretty good, but look at the images that we get with the high-resolution transducers here, the C29 and the transvaginal transducers, and no denying that these are the ideal kind of images for high-performance ultrasound in the first trimester, where you can see the nasal bone, the palate, the chin, and various other structures very well. So that's the spine here. And this is, of course, the most ideal view that you could have for your NT evaluation. You can see the fourth ventricle with the choroid plexus, the nuchal translucency, that is the thalamus, that's the nasal bone, that's the palate, and that's the chin here, and you can do all the measurements of the various angles, which we will come to. So transvaginal definitely, and also high resolution transducers do provide a distinct advantage over the transabdominal imaging. At an earlier stage, about 11-20 weeks, the fetus may be vertical and you may not get good images transabdominally. And you can see this is fetus at 12 weeks, but we were just not getting good images. And the same fetus, unfortunately, if you see transvaginally, you see that there is nuchal edema, there is pleural effusion here, or pericardial effusion, as you see here, and there is reversal of the ductus venosus in the A wave. So this kind of information is definitely important when you're dealing with a fetus where the visualization is not important, not good. And here in the three-vessel trachea view, the same fetus you can see with marked edema is showing reversal of flow in the aorta, suggesting that this is an aortic atresia, and that's a normal three-vessel view in another fetus. This is another fetus, transabdominally, slightly earlier picture, 9 weeks, 6 days, and I don't know why we did the transvaginal scan, but I think it was because the head was looking a bit irregular to me, and I always look at the contour of the fetus. The contour should be perfectly symmetrical, as we'll talk later. Here, the contour was not looking to be good, and lo and behold, when we did the transvaginal scan, you can see that this was a holoprosencephaly. So just to show you that from the sagittal scan, which showed a slight suspicion even before the 11 weeks, so at around 9 to 10 weeks, we can see that you can pick up the most lethal malformation. That's the normal butterfly sign, and you can see that there is holoprosencephaly. So when we are doing the NT scan, we, of course, owe a lot of our benefits to Professor Kypros Nicolaides, who inverted the pyramid and made us focus on the 12-week scan, which is really the most important scan today in the armamentarium of aneuploidy screening. So what we look for, as I said earlier, is biometry, aneuploidy screening, malformations, maternal complications, and multiple pregnancy. Of course, we will not talk about this. We will focus on the first three here. And when we look at biometry, again, as I said, if you have a small fetus, CRL is really the most accurate method of doing biometry. You first rule out a late conception, rule out wrong dates, and long cycles, menstrual cycles, which may be the cause of a small fetus. If all these three have been ruled out, or your LMP has been corrected appropriately, then we start thinking of whether there is a genetic abnormality. And specifically in 1813, triploidy and Turner, we can have a smaller fetus as compared to trisomy 21, where the fetus may not actually be small for the gestational age. Very important to remember that when the discrepancy is more than 7 days is what we take as significant. And as I said earlier, we need to rule out irregular periods and, of course, structural abnormalities. If you've got an anencephaly, for example, this is definitely going to lead to a lower CRL. And it's important that we do not mistake this. There are various charts available for measuring the CRL. We essentially use the Hadlock chart described in 1992, and this is quite an appropriate chart, but you're free to use any chart. As I said earlier, you must also look at body proportions, and you see here this is a twin pregnancy where one fetus had normal body proportions, the other fetus had a markedly small abdomen circumference. As you see on the sagittal scan, the abdominal diameter was smaller compared to the head diameter. And this is a hallmark, or can be a hallmark for a chromosomal abnormalities. In this particular case, it was a triploidy, it could also be a trisomy 18. And there could be other findings like a partial mole, where there could be syndactyly, cystic placentas, and first trimester abortion. The most important can be due to triploidy. So when we're looking at aneuploidy screening, We, of course, owe, as I said, a lot to Kipros and, of course, to Sir Langdon Down, who in 1828 described the earliest signs of trisomy 21 in the form of a loose skin, flat face, and a small nose, which Kipros took up at about 1990, and he used this single NT image to describe the risk estimation for aneuploidy. And going on from there, we measured the NT, and you can see here that's a normal NT here. That's a perfect image, and compare it to this image where you don't see the nasal bone here. You also see a defect in the palate, which we'll talk about later, and of course there is nuchal edema. So once there is nuchal edema, there is a 65% prediction, a 60 to 70% prediction of an abnormal karyotype, specifically trisomy 21, but can also be the other aneuploidies. It can also be that you can have a nuchal edema between the 5th and the 95th centile in some normal fetuses, so that has to be remembered. The moment you have an abnormal fetus with increased nuchal edema, this is a good chart I like to show my patients, because not always will there be an abnormality, and you can yet have a healthy live birth. So even if you see a 4 millimeter NT can have a 70% chance of a healthy live birth. As compared to, of course, as the NT increases, the chance of a live birth does decrease. We always use NT with free beta HCG and PAPE as a combined screening, and this is where we get our detection rate of about 90% with a 5% false positive. And if you can see the history of screening for aneuploidies, as it began in 1970, where detection rate was as low as 30%. In 1980s, with the triple and the quadruple marker, we improved to about 70%. And in about 1990s, when Kipros described the NT with the elevated beta HCG and the low PAPE, our performance improved to about 90% with a 5% false positive rate, and the output of a nuchal scan increase. So this is a two-stage algorithm that Kipros has recommended for a 90% detection of aneuploidy, wherein which if we do a combined screening and we have a risk of more than 1:100, we offer CVS with QF-PCR and microarray today, and this will pick up about 85% of our Downs fetuses. This will be, of course, seen in about 1.5% of our population on screening. The other extreme will be where we get a risk of less than 1:1000, and here we really don't need to do anything except do an anomaly screening. Of course, there is a small chance of Downs here, less than 1%, and this will be, of course, about 83.5% of your screening population. The intermediate group, where the risk is between 1:100 to 1:1000, will be about 15% of your screening population, with about 14% of Downs babies in this population. And here we use other markers, either ultrasound markers like nasal bone, tricuspid regurgitation, ductus venosus, or today we use NIPT in this risk group. So let's look at some of the new markers that Kipros has suggested. Of course, absence of nasal bone, they have been around since some time now, and all of us are adept at using it. And there is reversed A wave in ductus venosus, and of course the tricuspid regurg. These are about independently about 60% accurate in picking up trisomy 21, and can also be positive in some 2 to 3 or 5% of euploid fetuses. So this must be remembered very carefully. But if combined with the NT scan, our detection rate improves to about 93 to 96%, and our false positive rate decreases to 2.5%, indicating that a lesser number of invasive diagnoses would be necessary for the same diagnosis. When we do a nasal bone analysis, it's very important that, again, the technique and the image is very, very important. So we see three distinct lines. The top line is the skin here, as you see here. The bottom line is the thicker, more echogenic nasal bone, and that's the tip of the skin of the nose. So these three lines have to be very carefully analyzed, and these two form an equal to sign, as you see here. Technique is very, very important. You should have the transducer parallel to the nasal bone between 45 and 135 degrees, and only then will you see the nasal bone. If you image in this direction, sometimes you may erroneously not see the nasal bone and may make a false diagnosis. There are times when we don't get a perfect midline section, and you can use a 3D image, as I'll show you later, a 3D volume, and you can see that it's very important to be in the perfect midline when you're taking the nasal bone, because even if you have a 10-degree rotation from the midline, you will see that the zygoma comes in here, and which is erroneous, which should not be there, and that will lead to foreshortening of the nasal bone. If you rotate 15 degrees from the midline and look at the picture, the zygoma is fully seen, and you will make the nasal bone disappear and call it an absent nasal bone. So that's very, very important that you don't have that in mind. So as I said earlier, when you don't get a good nasal bone picture in a perfect midline, you take a volume, and then with multiplanar reconstruction, you can come and narrow down on the nasal bone here using a volume. And this is, of course, showing you the absence of the nasal bone as here. And this, again, like all the other markers, will increase the detection rate from 90 to 93% and decrease the false positive from 3 to 2.5%, making less number of invasive procedures necessary. It is a difficult technique, and therefore you have to be careful. And the other problem is that in 5% of normal Asian population, the nasal bone may be seen, may ossify at a later date, and this is very, very important from our point of view. And you can see here, by rotation, you're actually making the nasal bone disappear, and that's the zygomatic bone here in the midline. So there are some opinions about whether you should measure the nasal bone length. You can measure it. It's possible to measure it, and there are charts available. On a rough basis, the nasal bone varies in length between 2.4 to 3.12 millimeters between 45 and 84 millimeters. So you can remember 2.5 at 45 and 3 at 84 as a rough guide, and anything smaller than that, as you can see here, this is a twin pregnancy which had a nuchal edema in one fetus with a smaller size nasal bone here. The reliability is of some questionable significance. In some papers, this paper has studied the reliability of fetal nasal bone measurements, and some authors believe that it is reproducible. The other authors believe that this is poor inter-observer and intra-observer reproducibility. So the truth is not yet out, but you can use it if you wish to measure the nasal bone. The second marker that we commonly use is, of course, the ductus venosus. And as you can see here, the umbilical vein enters the abdomen, and in the mid-sagittal view, where it narrows and shows you a bright echo, we have the area of the ductus venosus, which continues into the venous vestibule. When you place the cursor there with a very narrow gate of about 0.2 to 0.5 millimeter, you will place the cursor here, and that's the reversed M wave, the M wave that you will get. You take about 4 or 5 images, as you see here, 4 or 5 waves, and the moment you get a reversal, as you see here, that can be an abnormal ductus venosus, signifying that there is an A wave reversal. Be careful, sometimes the hepatic vein may superimpose and cause a false appearance due to the hepatic vein image there, suggesting that that's a false positive, as you can see here. You can measure the pulsatility index, and the normal pulsatility index is about 0.92, 0.98, and the variation is from the 5th to the 95th is about 0.73 to 1.22, as you can see here. And it's important because there are some studies which have highlighted that fact, and I'll just talk about that. The moment you have a reversed A wave, you have an increased risk of aneuploidy and also congenital heart diseases. And as you can see here, about 60% chance of having trisomy 21, but can also be seen in about 3% of euploid fetuses. So here again, the detection rate improves as I said earlier, to 95%. It's also a risk factor for cardiac defects. So more as the nuchal translucency increase and you have A wave reversal, there's a higher risk of cardiac abnormality. As you see here, and combined with PAPE, it has an inverse relation. So lower the PAPE, and if you have A wave reversal, higher the risk of fetal death is seen with the abnormal ductus venosus. Now, as I said earlier, this is the pulsatility index. When you measure the pulsatility index, it signifies a greater. The red here is the pulsatility index, and the sensitivity of pulsatility index is higher in predicting cardiac disease as compared to just a reversal of the A wave, specifically when we are dealing with the enlarged NT. Although it is a variable which is independent of the degree of NT enlargement, but when the two are put together, it does indicate a higher risk of both aneuploidy and cardiac malformation. So the common cardiac malformations that can be seen with an abnormal NT are the AVSG and the hypoplastic left heart. So when you put it in the same algorithm of the intermediate group population, if you have an absent or reversed A wave or the nasal bone absent, your risk increases to about more than 1:100, and we offer invasive testing for these fetuses. Now, sometimes in the earlier days, we used to have what is called as the cystic hygroma. If there were septations in the edema behind the neck, we would call it a cystic hygroma, but that's no longer important, and all of these have the same significance or relevance as an enlarged NT. If you have generalized edema here, this is probably the most common abnormality that you will see in the first trimester. Look for a cardiac abnormality, and the moment you see a small aorta, you know you're dealing with a coarct, and this is very, very specific for a Turner syndrome with large cystic hygromas and generalized hydrops, what we call as spacesuit hydrops. Let's look at some other lesser important soft tissue markers, and there has been some importance to look at the hepatic artery as described by Bilardo et al. In 2011, again for the intermediate group. And what exactly was done was we looked at the hepatic artery and measured the velocity. Normal velocity being less than about 10 to 15. And if you have a higher peak systolic velocity, it may suggest an enlarged liver, which is, of course, a marker for Down syndrome. The other marker which is proving to be of some good importance is the insertion of the umbilical vein directly into the IVC, bypassing the ductus venosus, or if there is agenesis of the ductus venosus. If it is an isolated finding, it may have good prognosis, but if it is non-isolated, specifically if it is associated with nuchal edema, then it's just a poor prognosis. Now, this particular fetus, you can see that there is direct insertion of the umbilical vein into the IVC, but there was no nuchal edema here, and at this stage, no other abnormality was seen. Compared to this fetus, where we were having nuchal edema here, and here also you see that there is direct insertion on the IVC, but what is most important is the presence of nuchal edema. And the moment you have nuchal edema, the prognosis is poor, and it suggests that the outcome will be bad. This could be a marker for Down syndrome here, as you see here, or abnormalities unrelated to Downs. It could be a cardiac abnormality, it could be other syndromic abnormalities, or you may find other cardiac structural abnormalities at a later date. So this brings us to the fact that when you are faced with an increased NT, what are all the abnormalities that you could be dealing with? One is, of course, cardiac defects, and higher the NT, higher the risk of having a cardiac defect, as you can see here. So anything more than 2.5 millimeters to 2.5 to 3.5, you start suspecting a cardiac abnormality. If you have an NT which is high, you can have unexplained fetal death in about 20% of the cases. You may have major abnormalities like skeletal dysplasia, and of course congenital diaphragmatic hernias in about 45% of the cases, and a lot of syndromes which can be manifest as increased NT. So it's not only about Down syndrome, and particularly in the younger women, if you have abnormal NT, then you look for a lot of other abnormalities, and it's not only Down syndrome, but we could be dealing with a larger burden of disease, as we shall see. So a huge number of syndromes and abnormalities, single gene disorders, which could be representative of increased NT. And here you see one of the cases here. This presented with increased NT. There was something wrong with the skeletal system, no flexion here. There was a cardiac abnormality, single outflow, single chamber with calcific density. And just because the NT was abnormal, we very aggressively looked for all these abnormalities, and we did a microarray. And what we found on the microarray was that this was an abnormality which I had never heard of. So glucose phosphatase isomerase deficiency, which is the third most common red cell enzymopathy after sickle cell anemia and thalassemia. So we wouldn't have come to this conclusion if we had not done the single gene analysis here. Another fetus with nuchal edema is actually a conjoined twin. This was another fetus with nuchal edema, and this is very important to remember, specifically if you have agenesis of the ductus venosus. We analyzed the entire works. We did a FISH, microarray, the infection screening, everything was normal. Did the second trimester scan, and as you can see here, there is persistence of nuchal edema. And this turned out to be on the gene panel as the classical Noonan syndrome, or what we call the male counterpart of the Turner syndrome. So there is nuchal edema persistent here, and typical facial appearances, specifically the ear, you can see very low set, horizontal. There's a wide forehead and flaring of the nostrils. This is, of course, a descriptive picture, not of the same fetus. And there are various variations of the genes that you can have. Specifically, this one was the PTPN11 gene missense variation in exon 8. And in this particular fetus, there was no cardiac defect, but otherwise you could also have a pulmonary stenosis. Now, moving on to the fetal facial angles on the midline sagittal scan, you know that facial dysmorphism is an important part of the phenotype of many syndromes. And a lot of angles have been described, and we'll only look at some important ones. Specifically, the first important angle which I commonly see is called the frontomaxillary facial angle, and it allows us to have an objective evaluation of the position of the maxilla with respect to the forehead. I would say position and size of the maxilla. The FMF angle, as you see here, is a line drawn from the posterior margin of the palate to the front of the maxilla and to extend it to the nasion, and it increases or decreases from 84.3 degrees at 45 millimeters to about 76. So the angle becomes more acute as the fetus progresses and decreases with the CRL. Because of the small maxilla in Down syndrome, the angle remains wide. And if you have an angle which is more than 85, again, it's a 70% predictor of a chromosomal abnormality, specifically Downs. And this improves our detection rate to about, like with all the other markers, to about 95%, with, again, a lower false positive rate of about 2.5%. It has no significant association, so it's an independent marker with NT, PAPE, or beta HCG. And it's therefore a good marker. And here you see a twin pregnancy with nuchal edema here. And when we measured the fetal facial angle, it was about 98.5 degrees. The second of the twin had no nuchal edema, but also had a small maxilla and a wide angle. And lo and behold, both the fetuses, which is a very rare situation, showed us a karyotype of Down syndrome. This was another fetus with a low combined risk. The nuchal fold was normal here. The biochemistry was normal, low risk, but there was tricuspid regurgitation and a wide angle of about, you can see the small maxilla, wide angle of about 94 degrees. And this again turned out to be a Down syndrome. Now, the problem with this angle is that a lot of experience is required. The exact mid-sagittal plane may not be always obtainable, and you reserve again this for the intermediate risk group patients, where again, if you have an abnormal angle, you would do a coronaculus sampling. Now, as you know that NIPT, we started having screening with NIPT in about 2011, and this improved our detection rate of Downs to up to about 99% and can be done from about 10 weeks onwards. So this is the new algorithm which Kipros is suggesting, and we'll talk about it later. But with NIPT, although the detection rate is high, we do have a lot of false positive cases being referred, and that this is creating a problem. So we must understand the true implications of an NIPT. NIPT is a genotype rather than a phenotype test. So it gives you the genetics but does not tell you about the anatomy of the fetus. And as you can see that in this particular paper, after doing NIPT with low risk, many abnormalities like Potter's, transposition, hydrocephalus, Epstein's were seen in these fetuses, and these would have been missed if you did not do an anomaly scan. Again, interestingly, an American obstetrician sent 5 samples of non-pregnant women for NIPT, and 3 came back saying genetically normal fetuses. So a lot of commerce is involved in NIPT, and we have to be careful. Again, here, the fetal fraction is very important. And if you see the detection rate, if you don't have a good fetal fraction, you could be dealing with low detection rate, much lower than the 99% as has been suggested for NIPT. Also, there is a 5% failure rate of an NIPT test. And if you have a failure in an NIPT, then your detection rate falls to, if you include all those fetuses in the total count, it falls to about 90%, which is no better than a combined screening. So women are not correctly informed about the real prevalence of congenital fetal anomalies once they have a normal NIPT. They are not informed about the limitations of NIPT. In some countries, they no longer even do 11 to 14 scans, and therefore a larger percentage of abnormalities are picked up at 20 weeks. So Kipros has suggested a unified approach to dealing with in the post-NIPT era, where the first line screening is the combined test. If you have a risk of more than 1:10, you will do an invasive test. Otherwise, you will do cell-free DNA. In the intermediate group, as I suggested earlier, if you're screen positive, you yet do an invasive test. If you have no result, you rely again on the combined screening, and if the screen is more than 1:100, you would do an invasive test. If cell-free DNA screening is negative, you do nothing else. And of course, if your combined screening is less than 1:1000, you don't do anything else. Let's look at malformations now, which is the third element of the first trimester screening in the mid-sagittal view. And this particular paper is important when you're looking at the abnormalities in the first trimester. You have a group of, by Singalaki et al., a group of abnormalities always detected is 31%, sometimes detected about 43%, and there will be some abnormalities which may not be detected. So these are the group of abnormalities which we must pick up, specifically acrania, holoprosencephaly, body stop abnormality, exomphalos, as I said earlier, and of course some cardiac abnormalities. And let's look at some of these on the mid-sagittal scan. The important on the face to see is, of course, micrognathia, and you have to be very careful in pronouncing micrognathia, especially on subjective evaluation, because this implies the fetus is abnormal the moment you say that the chin looks small, and this may be less apparent with continued growth and development. Again, you must remember there's no gold standard, and therefore it's very important because micrognathia can be associated with a lot of syndromes. As you know, that micrognathia, or the underdevelopment of the mandible, is due to first pharyngeal arch abnormalities here, and can be part of various syndromes, as you see here, specifically the most severe form being the Pierre-Robin sequence. Now, it can be very subjective. Is this a small mandible? as you can see here, and probably in another fetus here. This definitely looks small. There are other abnormalities. There's dilated jugular sac. There is, of course, NT, which is 3 millimeters. And, of course, there is syndactyly. But in most of the situations, we would need objective measurement on the mid-sagittal scan. And here we have the mandibulomaxillary angle, called the MMF angle, mandibulo-maxillofacial angle, where we drop a line between the mandible and the maxilla, and this is the MMF angle, and it decreases with gestational age. In chromosomally normal fetuses, both the FMF and the MMF angle decreases. The MMF angle decreases from 114 to 103, as you can see here. And the ratio, because both are decreasing, is constant, about 0.74. If the FMF angle increases, as you know, as we saw earlier with Down, and the MMF angle decreases, the ratio increases, and this suggests that we are dealing with a micrognathia, and is highly specific for conditions like this. So it's very important to measure the mandibulomaxillary facial angle. The other angle that's important is the maxilla, nasion, and mandible angle. And here you take a line from the protruding lip to the nasion and to the mandible. Average is about 11 degrees. If there is micrognathia, this angle will increase to about 16 degrees, as you see in trisomy 18. And this again is quite a specific sign. So this is quite a good angle to measure. There is, of course, the inferior facial angle, where you drop a line from the mandible and cut it to a horizontal line coming from the nasion. And this is usually about 65 degrees. But with micrognathia, this decreases below 49. This is essentially a second trimester scan, but you can also use it in the first trimester. Let's look at first trimester clefts on the mid-sagittal view of the face. So as we know that palatal fusion is complete by about 11 weeks, and evaluation of the palate is possible on the after about 50 millimeters CRL. And we look essentially for the intact palatal line on the sagittal view. As we know, the cleft lip palate is seen about 2 per 1,000 live births and can be part of a lot of syndromes. It's a complex development that takes place at about 8 to 10 weeks. We have fusion of the frontonasal process, the lateral nasal process, the maxillary process, and the first pharyngeal arch. And in time immemorial, people have measured the palate. And as you can see, the palatal length is measured here as early as 1965. And you have the charts available for measurement of the palate. But it was Rabi Choi who first described the maxillary gap sign here, looking at the intactness of the palate. And if you see a lucency here, suggesting a high risk for cleft lip and cleft palate. And the accuracy, if you see, was 96% of cleft lip palate with additional abnormalities, 65% with isolated cleft lip and palate, and can also be seen in 7% of normal fetuses. If you have a large gap, then that can be seen in about 69% cases of cleft lip palate and 35% of isolated cleft lip palate. So there's a lot of false negative that is possible, and these were some of the images that you can see here. So although it's a very good sign, but we have a lot of variability in the appearance. And this is one such case. You can see there's depressed nasal bridge here, flat face. There's a lucency in the palate here, and that's the defect in the lip you can see on 3D imaging. That's the defect in the palate. On the axial imaging, this fetus, of course, had holoprosencephaly. You can see a monoventricular cavity and microphthalmia and other abnormalities syndactyly. And you can see the advantage that 3D provides in giving you a good facial profile. Also, there was a phallostratrology. This was trisomy 13. Now, coming back to the palatal line, you can see here that this is the appearance of the palate. It widens as you go posteriorly on the mid-sagittal section. And you can actually see two lines posteriorly as you go here. which is the appearance on this graphic here, as you see. Now, what exactly is the two lines? And this, I think this explanation I owe to Dr. Lakshmi. She presented a wonderful paper in the White Journal. And what you actually see is that when you are exactly in the midline, there is the vomer bone which superimposes the palatal bone here. And you will actually see this when you come parasagittally as two lines here, because you don't see the vomer bone here, which is a little more midline. So that is the vomer bone superimposed on the palatal bone. And when there is a cleft palate, sometimes it may be missed on the midline section, because the vomer comes and sits on the palate, and you see a continuity as the intact palatal sign. And this is what you will see here. But if you're very astute, you will see that there are no two lines here. And this is the paper which she presented. I'll just give you a brief of what you see. When you see unilateral cleft lip palate here, as you see here, there will be absence of the palatal line parasagittally. In the midline, the vomer, as I said, drops down and you will see intactness. But the moment you come on the side here, you will not see the palate. And that's how you diagnose a unilateral cleft palate. When you have a bilateral cleft lip with a cleft palate in the midline, you will get premaxillary protrusion. So you see a premaxillary protrusion here with a defect here, and this is due to the presence of the vomer bone, which falls down in the midline here, where you see the continuity of the palate here. So this is actually a huge defect in the palate, but because the vomer is falling down here, this is what you will see. In a median cleft, what you will see in the midline is absence of the proximal portion of the palate, and the posterior portion is again formed by the vomer bone. The moment you go parasagittally, you will see interruption of the palatal line, and the anterior portion is intact due to the presence of intactness of the alveolar ridge there. If there's an isolated cleft palate with rectognathia, the distal portion of palatal line is absent, and the proximal portion can be formed by the alveolar ridge, and the posterior portion parasagittally by the vomer bone. So it's very important that you understand this whole dynamics and look at the entire palatal line in the mid-sagittal view and parasagittal view. And of course, if you have 3D imaging, you can use the axial view from the sagittal view to get a complete look at the palate. Let's now move on to looking at structural abnormalities as a good in the mid-sagittal view. And if you can see that here, this is a twin pregnancy, and no, I don't have to tell you the diagnosis. This is the acrania, exencephaly, and anencephaly sequence. And you can see here that this fetus, the frontal bone is intact, but in this fetus you don't see the frontal bone, but intactness of the brain, and this is acrania. And over a period of time, this will get eroded and will turn to look like this fetus. You may see other fetal malformations in 12%, and don't forget that even in anencephaly, you can have a chromosomal abnormality in about 5%. Now, this was a lovely paper presented by Simon, who described the various types of anencephaly. So you have a Mickey Mouse type, the foreshortened type, the elongated type. If you have multiple cystic areas, this could be due to ischemic etiology of anencephaly rather than a folic acid deficiency, and you can have the overhanging type and the irregular type. And this is the twin pregnancy with one fetus having nuchal edema and the other fetus having a cystic appearance of anencephaly. These are all the elongated types, with some with cystic areas and some with irregular appearances. And this is the Mickey Mouse sign, where you have split bilobes, split cerebral hemispheres dangling freely in the amniotic fluid. And this can be part of some syndromes. This is the typical overhanging type, and as you know, we call this the Donald Trump sign, and he's of course on the news every day, maybe sometimes giving us not so good news. The other abnormalities that we can see on the sagittal view are the encephaloceles. They can be usually posterior, but some can be frontal and some can be lateral. They can be associated with other abnormalities, as you see here. This was an interesting fetus where on the sagittal view we were seeing a defect here with no protrusion. On the coronal view, there's complete absence of the half of the skull bone here, and this could be due to an amniotic rupture sequence. It's an asymmetric cephalocele with a mild protuberance here. You can have a Meckel-Gruber syndrome associated with the encephalocele with cystic kidneys and polydactyly. Then you can have other facial abnormalities on the sagittal view. This is an oropharyngeal teratoma that we picked up. When we look at the sagittal view, as I said, always the contour is very smooth. And if you see some abnormality of the contour, this highlights us to an abnormality. And in this particular case, you can see this abnormality here at 8-9 weeks was spina bifida at about 11 to 13 weeks. The IT sign described by Ravi is very useful for picking up on the mid-sagittal view spina bifida, and basically these are representing three lines: the posterior margin of the midbrain, posterior margin of the fourth ventricle, and the cisterna magna, and that's the choroid plexus in the fourth ventricle. The IT sign is quite sensitive in picking up about 50% sensitivity, but very specific, 99% for picking up open spina bifida. It may not pick up closed spina bifida. So we need to look at other markers which improves the specificity, and these are the brainstem diameter, the brainstem to occipital bone diameter, and the brainstem to brainstem occipital bone ratio. And this is important because when there is a spina bifida, the brainstem will herniate, it will widen, it will compress the fourth ventricle, and these ratios will then get altered as you see here. Basically speaking, you will get widening of the brainstem and decrease in the brainstem occipital ratio, which will increase to beyond 1. And you can see a case and example. There is widening of the brainstem seen here, compression of the fourth ventricle, and lo and behold, there is a spina bifida, as you can see here in this particular case. Another fetus where twin pregnancy, where you see widening of the brainstem here and compression here, and this fetus also had late development of hydrocephalus. Now, there is another angle described by Nicolaitis to pick up a spina bifida, and basically again signifying that there is herniation of the brainstem leading to flattening or posterior movement of the frontal bone. So this is called as the frontomaxillary facial angle, again, which we use for Down syndrome. If the angle becomes more acute, it suggests a high risk for spina bifida. Simon also described another line between the maxilla and the occiput, and if you see the brainstem going below this line, that is the thalamic diencephalon, that again is at high risk for spina bifida. On this sagittal view, you may pick up spinal defects directly also. So here you see there is a segmentation defect with the diastomatomylia, and another fetus with scoliosis, suggesting that this could be a part of various syndromes. You could see abnormalities at the caudal end of the spine here. This could be a sacrococcygeal teratoma, as you can see here, and again making an abnormal contour. A few minutes on evaluation of the posterior cranial fossa in the sagittal section. You can see here that the three cystic spaces, as you can see here, on the sagittal view that we described, the prosencephalon, mesencephalon, and rhombencephalon. And at 10 weeks, we have development of the cerebellum here. As you can see here, it protrudes into the posterior cranial fossa and closes the communication between the fourth ventricle and Dandy Walker. And at this point, at about the CRL of about 17 to 18, you have kinking of the pontine flexure, and the roof of the fourth ventricle is open. And that can be seen on a biplane imaging obtained with 3D. As you've seen here, the parasagittal imaging, that's the kinking of the pontine fossa, the development of the cerebellum happening here, as you can see here in these images. And here, this is a normal, that's the choroid plexus of the fourth ventricle here, development of the cerebellum, and that is missing here, suggesting that this could be an early onset Dandy-Walker malformation. There is widening of this posterior cranial fossa. So let's look at a fefew abnormalities. This is typical of a Blake pouch cyst, where you have the vermis seen here on the sagittal section. The brainstem is well formed, anti-clockwise rotation and communication of the fourth ventricle with the cisterna magna. In this particular case, there's an occipital encephalocele with a wide gap communicating the posterior cranial fossa, fourth ventricle with the cisterna magna, and absence of the vermis here. In a Dandy-Walker, you have widening of the, so instead of the narrowing of the fourth ventricle, you see here there is widening of the fourth ventricle here, and with spinal abnormalities. And on the sagittal view, you can also see sometimes that the cisterna magna is completely not visualized. And this suggests that this is a Dandy-Walker malformation. You do a sagittal reconstruction, and you can see there is marked anti-clockwise rotation of the vermis in this particular case. Another important abnormality that can be seen when you see a widening of the fourth ventricle is with associated marked ventriculomegaly on the sagittal view. Normally, the choroid plexus will occupy this space here, and you can see that there is complete ventriculomegaly, and there here at 12 weeks to 13 weeks, there is yet acute kinking of the pontine flexure, and you don't see the vermis well formed here, and again indicating an abnormality, and this is of the Walker-Warburg syndrome, or what we call as the kinking of the brainstem sign on the sagittal view. And this could be a part of various syndromes. This was another fetus with similar presentation of hydrocephalus with enlargement of the skull, widening of the fontanelle, but lo and behold, you see on the transsectional view that this was unilateral and the other ventricle is not dilated. So isolated foramen of Monro obstruction. Can we see the corpus callosum on the sagittal view? Maybe not directly, but we can look at indirect signs of the corpus callosum, and you can see here that this is the upper margin of the lucent area, the thalamus, and the third ventricle. And there is a good sign which is described. So we take the midbrain to Fox ratio, that is the midbrain to Fox ratio here. We drop a line from the sphenoid bone here to the upper margin of this lucent area, and that's the midbrain, and the upper margin of the Fox from here. And this ratio is normally 0.5 to 0.6. When there is agenesis of the corpus callosum, the midbrain will move up, and this ratio will increase. So the midbrain gets elongated, and the Fox will decrease. So that's the midbrain to Fox ratio, which will increase with agenesis of the corpus callosum. And we have the charts of all these ratios available. So normal ratio is about 0.5 to 0.6. And when there is increase to about 0.8, it suggests that this could be an agenesis of the corpus callosum. And of course, with slow flow imaging today, we can actually see the pericallosal artery. And when you see arborization of the vessels, this could be a marker for agenesis of the corpus callosum, an indirect sign. And here we have a fetus with multiple abnormal cystic areas here. As you can see here, the axial view shows holoprosencephaly. There is a dorsal sac arising from the roof of the third ventricle, as you see here, and on the sagittal view, there's of course polydactyly, marked nuchal edema, and also you can see that there is widening of the midbrain here compared to the Fox. So you have a combination of holoprosencephaly with agenesis of the corpus callosum. On the color Doppler, specifically for holoprosencephaly, when we see the pericallosal artery, we know that it is a little distance away from the frontal bone. But if it is closely applied to frontal bone, this suggests the snake under the skin sign, which is a marker for holoprosencephaly. Moving to some ventral wall defects in the anterior abdominal wall, you know that when we see the mid-sagittal scan, these are the other lethal abnormalities that we can pick up. You can see it in about 1 in 2,000 live births, most common being gastroschisis and omphalocele. The other uncommon ones will be ectopia cordis, limb body wall complex, cloacal extrophy, and the urachal cyst. And we have the embryonic plate, which is flat at 4 to 5 weeks, and then there is a folding or convergence cranially, caudally, and both sides laterally, and this compresses the extraembryonic coelom, and the fetus closes ventrically, and by at about 8 weeks, we only see a little protrusion of the bowel into the base of the umbilical cord, what is called as the physiological hernia, and it measures less than about 7 millimeters. So any persistence of a defect which is more than 7 millimeters, we call it an omphalocele. The gut fails to return. It's usually due to small bowel, but if it's a wide defect, sometimes, of course, you can also see the liver. And these are some of the differentiation features between the different types of ventral wall defects, the omphalocele and the gastroschisis. Specifically, if you have a covering over the defect, we call it an omphalocele, and if you have free-floating bowel loops, it's a gastroschisis. This, of course, is less associated with chromosomal abnormalities and other abnormalities as compared to omphalocele. So what do we look for? We look for a limiting membrane. Where is the umbilical cord inserted? Is it at the apex or on the side? What are the organs? What is the appearance of the bowel? Of course, are there any associated malformations? And we can have different defects. So more cranial the defect, it could be an ectopia cordis. A defect in the umbilical region could be a medial omphalocele and a gastroschisis. A caudal defect could be a bladder and cloacal extrophy or an OEIS syndrome, or they could be asymmetric multiple abnormalities, what we call as the body stalk abnormality. And here, as early as 8 weeks, you see multiple amniotic bands with ventral herniation, suggesting that there is a pentology of Cantrell or a cranial defect here with protrusion of the heart. And this is a more gross disturbance. You can see that along with the heart, even the bowel and the other viscera are herniated, as you see on the sagittal scan. So when we're dealing with omphalocele, these are usually midline defects seen at the apex of the umbilical cord is seen at the apex. It could be small with bowel, it could be large with the liver herniating. The smaller ones are more harmful because they can be associated with chromosomal abnormalities and have poor prognosis. And 2/3 will be detected at the first trimester, and of course, a large percentage will be terminated. The epigastric ones, which are large, may look alarming, but they usually have a good prognosis, and they will be less associated with chromosomal abnormalities and more having liver contents. You can have a lot of chromosomal abnormalities, cardiac defects, genitourinary abnormalities, neural tube defects, GI abnormalities, and musculoskeletal abnormalities. So you need very careful analysis. When the moment you get a chromosome, an omphalocele, we need to look for other abnormalities. We could have maternal complications in the form of oligopolyadrenose, IUGR, single umbilical artery, placental chorioangiomas, and of course immaturity and prematurity. This is an 8-week fetus here with slight nuchal edema with physiological herniation. Same fetus at 10 weeks, cleft lip, absent nasal bone, nuchal edema, and you see a ventral wall defect. And you can see that there is a reversal of the ductus venosus and limb abnormalities, and all this was due to trisomy 18. So chromosomal abnormality can be seen in about 30 to 40%, 50 to 70% will have other major abnormalities, and specifically if it's intestinal contents, there could be syndromes like the Beckwith-Wiedemann syndrome. And if it is isolated truly, then 86% will have a normal outcome, specifically with normal karyotype. And here you see bowel and liver herniating into the omphalocele. Another fetus with an omphalocele with liver and multicystic dysplastic kidney, as you can see here, with a cranial defect also seen here. And this is another fetus, small omphalocele with bowel contents. You can see the mesenteric artery herniating into the omphalocele with the flow seen on Doppler. And that is the 3D image with tricuspid regurgitation also suggesting that there could be a cardiac abnormality associated with this fetus. This fetus had a widening of the intracranial translucency here, suggesting that this could also be an associated Dandy-Walker malformation. What's important to remember is that in 40% of cases, what we consider to be isolated may not actually turn out to be isolated. Prenatally detected omphaloceles have worse prognosis as compared to the postnatally detected, and the larger ones usually contain liver and therefore have less problem. On the other extreme, the gastroschisis with free-floating bowel loops, the prognosis is good. There's no covering membrane here, and usually not associated with a chromosomal abnormality. But they do have bowel abnormalities, which of course manifest in the second and third trimester. And that could be in the form of bowel dilatation and IUGR. Now, in this particular case, if the defect is more caudal and you don't see the urinary bladder, that is a marker for bladder extrophy. So you see a subtle bulge here, and again, there's increased risk of aneuploidy. Now, you see here a 10-week fetus with irregular contour seen here. We are not seeing the bladder here. The umbilical cord is displaced onto the midline, and that 12 weeks becomes more prominent. But what's most important is that there is disruption of the triangle that is formed by the umbilical vein going into the ductus venosus and the umbilical artery and the aorta, and that is a marker for bladder extrophy. And you can see here at 18 weeks, finally, we don't see the bladder and caudal defect suggesting that there is bladder extrophy. And this is what I was talking to you about. That's the normal triangle that is formed here, and this is what we call as the K sign. The moment you see disruption, that's a marker for a cloacal extrophy. There's another fetus here with an irregular shaped bladder or septated bladder appearance, disruption of the K sign, and you see abnormal cystic area here, and again a herniation, which is what is called as a cloacal extrophy here, as you see here. The severest form of a ventral fold defect is what we see as a limb-body wall complex. There are bizarre complex defects. There can be attachment to the placenta, short cord. You can have limb malformations, scoliosis, cranial defects. The two types can be craniofacial or urogenital, and this is an extreme form of a limb-body wall complex. You see there's also an occipital encephalocele, gastroschisis, there's scoliosis, and almost this is the 2D appearance, more remarkable. That's an omphalocele also seen here, and more remarkably seen on the 3D appearance, as you can see here. So these are other appearances of limb-body wall complex. You see amniotic rupture sequence with multiple amniotic bands causing asymmetric abnormalities. That's a short cord, is a bladder which is adhering to the placenta. So different appearances, varied appearances, extracoelomic positioning of the organs, and these are all gross deformities, so this should be picked up in the first trimester and terminated. It could be a part of a syndrome, what we call as the OES-IS syndrome. So there is omphalocele, extrophy of the cloaca, imperforate anus, and there could be spinal defects. You see here, there's a cloacal extrophy. As you see, markedly short cord with meningomyelocele and spinal defect here. Finally, we come down to appearance of bladder abnormalities. The moment you have a distended bladder which is more than 7 millimeter in the vertical diameter, we know we call this as megacystis. It is an ultrasound finding, and it's easy to identify but difficult to manage because of its varied etiology and uncertain evaluation. You could have low urinary tract obstruction as one of the causes. It could be genetic syndromes, developmental abnormalities, and chromosomal abnormalities. So how do we handle megacystis? Anything that is more than 6 millimeters, or if the bladder diameter related to the CRL diameter is less than 10%, that's normal. Anything more than this we call as megacystis. We have two broad groups. If it is up to about 15 millimeters, there's a high risk of chromosomal abnormalities, almost 20%, trisomy 13 and 18. 90% of these will resolve. If it's more than 15 millimeter vertical height, suggesting that this is more due to an obstructive, progressive obstructive uropathy, like urethral agenesis in the female, and this has a lower incidence of chromosomal abnormalities. So we offer prenatal diagnosis, repeat scan, because some of these may resolve, discuss termination if it is not resolving or if it is associated with chromosomal abnormalities, and there have been people who have considered antenatal interventions. So if you can have an abnormal nuchal edema associated with this, indicates aneuploidy. If there's omphalocele associated with the bladder megacystis, this is part of OEIS complex, and specifically if you have a spinal defect. And of course, if you have a bladder diameter which is twice the gestational age diameter, then this could be a cloacal malformation. And if it's associated with spine and skeletal abnormalities, this could be a vectoral abnormality also. So which fetuses will be suitable for intervention? If you have an NT which is less than 95%, if you have a bladder diameter less than 12 millimeters with umbilical cord cysts, these are probably the ones that may resolve and may be suitable for intervention. So some studies which suggest that you can even put in a shunt as early as the first trimester. Now this was an interesting fetus with megacystis seen here at 13 weeks. 16 weeks, bladder disappeared. It was normal, and we were seeing a cyst in the abdominal cavity here close to the stomach and kidneys, so it was a mesenteric cyst, and it decreased. We did all the analysis, was normal, and by about 30 weeks all the cysts had disappeared and a good outcome was possible. Compared to another fetus, twin pregnancy with megacystis here and nuchal edema, you can see that in this particular fetus there was a single umbilical artery with hydronephrosis and a septated appearance of the bladder, suggesting that this is a cloacal malformation. You can also see some enteroliths suggesting that there is a fistula, and this was as early as 12 weeks. Finally, a few other abnormalities that we can pick up on the sagittal scan are the abnormal placement of the stomach in the chest, that is a congenital diaphragmatic hernia. And in this fetus, you can see here that on the 3D picture, you can actually see a protuberance, which was actually the heart getting displaced to the right side and causing a prominence here on the 3D image. And at 14 weeks, you can see the full-blown congenital diaphragmatic hernia. Parasagittally, we must look at the limbs, and you can pick up limb abnormalities. Here you can see limb reduction defects, so there's only monomelia here. In this fetus, there are a lot of abnormalities. That's the abdominal image, and the sagittal image showed complete absence or transverse limb defects involving all the limbs. This was a fetus with a fused lower extremity with a single umbilical artery, suggesting a serenomyelia, usually associated with agenesis of the kidneys. And you can have limb movement abnormalities. This is arthrogryposis complex congenita at 13 weeks. You see fixed flexion, 15 weeks, again fixed flexion, no movements, and of course there's other fetus with fixed flexion here. This is a rare abnormality called the lethal multiple pterygium syndrome, where there is hyperextension of the fetus with a lot of flexion abnormalities, fixed contractures with large amount of cystic hygromas all around. And finally, to conclude, you have an early diagnosis in this multiple pregnancy here at about 14 weeks. You can see that this is an anencephalic fetus. As I said earlier, look at the contour, abnormal contour. There was another of the fetus with a parasitic fetus, so a trap fetus here. And a third fetus had a small defect at the spine, which we saw later as a meningocele. So 3 out of 4 fetuses had abnormalities we had to reduce. So the sagittal view is important for the intervention. We reduced these 3 fetuses, and have finally had one residual fetus. So in conclusion, today we have a powerful midline sagittal view which can give us information not only about aneuploidy screening, but a lot of other abnormalities that we have highlighted in the text earlier. So it is a single view with maximum benefit. It is the best time to do biometry and do combined screening for aneuploidy screening. It gives us very important anatomical information. Color Doppler can be useful to give us physiological information. But what's important, and you must be cautious about, is that the technique is very, very important. You have to have the perfect horizontal position, get the perfect midline view, the perfect sagittal view, use appropriate magnification, neutral position, of course, transvaginal and 3D imaging as highlighted. And in conclusion, although this is a virtual Congress, I invite you to have a drink with me, which I shall be sharing shortly. And I thank you for this webinar, and please have dedication and patience with our situation at the moment. Do aim high and play safe. Thank you very much for a patient hearing, and I invite questions at this point of time.